Now I invite Dr. Princy Louis, HOD, Department of Pharmacology, AIMS, Kochi, to take over the session on operational requirement for Ayush vigilance. Welcome you, ma'am.
So, good morning, everyone. Let me thank the organizers, the principal of our Ayurveda Medical College, and that is Dr. Ramesh, Dr. Pradesh, and giving me this opportunity to stand in front of you. And I was listening to the wonderful lecture given by Dr. Bedekar, and I'm a pharmacologist, sir. So I agree. And the need, I have also worked with Tricatu, antibacterial effects. I have done Trifala. What we were doing is we are trying to prove that this has been working since the ages. And we have to prove it by doing therapeutic drug monitoring and reporting. So my session is on ADR, how you report ADRs. And with the compliments from Dr. Galib, I'm here to do my session with you today. So, dear friends, uh, do we have adverse reactions with Ayurvedic drugs? If you take a coin, if you take any coin, heads and number, right? So, there is an action, there is a reaction. Newton's third law of motion. For every action, there is an equal and opposite reaction. That's what he has said. Now, the reaction may be less or more, that's a different factor. Okay. So, what I'm trying to say is anywhere there is action. Okay. So, there is something that happens. So, how do we go about doing it? So, our specific learning objective today is how to run an or ADR monitoring center, of which the Amrita Ayurvedic College is a member. We are one of the first members. And I remember when we started the AMC here, Pharmacovigilance, you all have diverted and become a Ayush Pharmacovigilance Center. Okay, so that's a great point here that we have. So today, to run this, what are the logistic supports you need? What are the physical things to do? And how you should report. These are what we are going through. Next slide, please. So we see how we have to act. We always have this thing of procrastinating. So let us act, don't wait. And always, when we start off, when we begin well, it is half done. Okay, so that's why we are starting off itself well. Next slide, please. So, is it risky to take a medicine or to do bungee jumping, jump from the cliff, parasailing, gliding, and all these things? Adventure sports are there. But is that as risky as taking a simple tablet, a medicine, a teaspoon of a nice syrup? They are as risky. Okay, that's why I put this slide to just draw a parallel. Next slide. And when we are giving medicine, the medicine has to bear the onslaught of the body, has to bear the onslaught of the medicine. And when are we giving the medicine? When the body is at a weak time. Correct? So the body has to bear double. So that is why this has been very beautifully put forward so that we understand how difficult it is when we take medicines. Next slide, please. So what is pharmacovigilance? It is the method by which we find out, detect, and collate and analyze and assess the adverse drug reactions, so that what we have to do, we have to prevent and put in measures in place. That is why we have this vigilance. What is vigilance? We have heard of vigilance officers, no? If you're taking a bribe, the people are afraid of vigilance officers. So vigilance means we are, now there was another word, surveillance. What is surveillance? Surveillance is also watching. So that is only watching. Vigilance means watch and take an action for something wrong done. So we are not doing ADR surveillance. What are we doing? ADR vigilance. Okay. So that is where we have to act. Next slide, please. Yeah. So we are looking at why we need to do pharmacovigilance, why we need to report adverse reactions, why we need to look at uh, collect adverse drug reactions, why we have to bother. If the drug is working, thoda kuch ho gaya, no problem, is it? No. We need to do, because it is the most ethical thing to do, and that is why we as physicians, what we say, Sukartam Sarva Bhutanam Mata Sarva Pravartayaha Sukam Sana Vina Dharmat Tasmad Dharmo Paro Bhavet. So what actions you do should be right for the ultimate happiness. Okay. So as a physician, you are to do right. What you have to do? You have to also do vigilance, okay, of adverse drug reactions. And that makes us need, it is our need. It is not because there is a rule that you have to report. It is not because Government of India, Ministry of Health, Ayush Welfare is telling you that you should report. You should report because it is our part of our duty. As we give the drugs, if we are seeing something different, we have to report it. So this is the importance of reporting. So there are, when we have adverse drug reactions, we have to quantify it. You have to see the trends across the country and across the world that comes together. And that gives us some answer and help. The amount that you have to spend to correct the adverse drug reaction is another expenditure for the government, for the exchequer, for the nation as a whole. Okay, so these are, next slide please. These are some of the reasons. So ethical aspect, that is what I told, and all humanitarian reasons, these are the reasons why we have to do adverse drug reaction monitoring. Next slide please. So we have this pharmacovigilance as a humanitarian cause we have to do, because these are tried. Now, this is for conventional medicines which we are talking, but Ayurveda is a system of medicine. Siddha, Unani, homeopathy and all have been coming from so many years. Homeo is more closer, but our Ayurveda and Siddha systems are thousands of years, okay, and they have come through, okay, but still we need to validate, okay. So next slide please. So the validations have not been done, so we need to do. So there is an organogram. This is called a organogram. This is typically Amritas. Okay, this organogram, this workflow chart we follow in Amrita. So we have adverse drug reactions being reported by the various departments, IP, OP, ICUs, OTs. From anywhere you can get the areas. And then how do we do? It comes to the regional training center that we are here at AIMS Kochi, and we report, plus there is quality division also gives us the report. Sometimes we get in 2-3 places, and ultimately all that we get at the RTC goes to the National Coordinating Committee, which is the same format for Ayush Vigilance also, and it goes to the CDSCO, it goes to the drugs controller. Okay, so if there is a serious adverse event, from here, Amrita, RTC, we also tell the clinical pharmacists and our AEPL, because they are buying the medicine. So to stop recall and all, we need to inform them. And we inform the drug inspector of the district. Now, when this adverse event goes to the National Coordinating Center, they tell the CDSCO, and the CDSCO directly tells the Kochi district or whichever district it happened, that drug controller. So you see, it is a panel. And whenever you report, you're a good doctor, you have reported. Now, don't you want something coming back to you? That is why we have this slide there. You know, it goes back to the reporter, what happened. Okay, so you get back as alerts. You have to be watchful. When you give dash drug, you should be watchful that it causes some pigmentation, patches of pigmentation, like that and all. These things come to light only when you and I report. And in the large thing, you see the signal is detected. Okay. Next slide, please. Now we start with the various steps for the to set up a AMC. Just going fast. So our step one is getting the letter of intent and this, which we already have, just for any other colleges to be coming through. Next slide, please. That is this. And then we go on to having a pharmacovigilance committee. You should have a committee which looks at it. Okay, it's never an individual person. Next slide, please. So we have to have the various logistics that are needed. We have to have reporting from all levels of persons. Next slide, please. We also go into the various aspects of finding out this logistic identification of space. Space you don't need very much, just a small 10 feet by 10 feet is more than enough, or 6 feet by 10 feet, something. Just a little office space where you can put table, chair, put a computer, so that you can have the VG the software is there, ADRMS software is there. Next slide, please. So we go to seeing how much more we need to do. So what are the other aspects that are included here? In this step, we are looking at how you complete it with having telephone connectivity. Next slide, please. Net connectivity. Next slide. Next. Okay, yes, okay, there we have it. So we have to have various aspects for storage. You need to store it in box files for the years, and we have to keep it for documentation for a long duration of time. Not only in physical, but also in soft. Okay, next slide, please. We need to have telephonic connectivity because somebody has to inform you. So it has to be, you have to have telephone connectivity. Next slide, please. We need to have signages that tell you where your AMC is. So this is how we have for ours. You must have seen there. Yeah. So we have to do various other activities in addition to this. That is, you have to do sensitization programs, and we need to have people working into it. Next slide, please. So we have, these are the committees that are being put through. Next slide, please. We have to write the committee meetings, minuted, and the file, the book, the register also should be always available for checking. Okay, every documentation is very, very important. Next, we have to see all the aspects of sensitization, and side by side there are programs that are being conducted. What are the programs that are needed to be conducted? You have to sensitize all our staff, junior most to the top. Okay, from top to down or down to top. Any which ways we have to have a sensitization every 3 to 6 months. You should have a sensitization. So at one time, people come in and go. So they are all sensitized and they know. So this is internal sensitization. Also, we have external sensitization. And what is external sensitization? The patient. Now, today's day, if I am going to get an adverse reaction, not only should the doctors and the healthcare providers worry, but me myself should be empowered and have the knowledge, and I should be able to report. So that is why we say, what do we say? We say external sensitization, where the patient himself is the stakeholder. So it's the patient or the patient's bystander also who can report. Okay, but their report may not be as acceptable as, but at least it is reported. See, friends, we are looking at how much we can catch. Okay, the catchment should be max. Sometimes the report, may not be true. There may not be an actual adverse reaction. But how do you know it is not? Only when we collect and see, then we know that, oh, that is not there, it happens. Then it is discarded. So you are sure. Okay, so without vigilance, we can't move forward. So to do this, next slide, please. We have to have also the various cooperation from various departments and OPDs we go for collecting and ferreting out the adverse drug reaction. When you say adverse drug reaction reporting, how is it? You just don't stand and say, give me adverse drug reactions from your department. No one will put it on a tray and offer it to you. You have to go and ferret out. Sister, the doctors there, you have to ask them, look at the case sheet, sudden change of drugs, something may be noted or not noted, but that is how you catch. Also, lab investigation. Suddenly, after putting this drug, the LFTs or the kidney or the blood counts has increased drastically or decreased drastically by 2.5 times, just because all this time patient was fine. So you are the clinician. You are the one who knows your patient. You know the drug, you know the patient. You know what can be expected. So who can suspect that could it be an adverse reaction? You, right? So please, if you suspect, report. Don't worry whether if it is it surely not, no worry, just report. If it is nothing, it will just fizzle out, in the vast amount of areas that the NCC gets, it will be fizzled out. Next slide, please. Yeah. So we have to have various activities and add-on activities, research activities. From this, whatever data that you're collecting, you're sitting on a treasure trove of a mine of gold. You're sitting on it. So what you have to do? You have to collect reports. Okay, with one drug, what are the areas that we are getting? Or all the Rasayana group of drugs, what are the adverse reactions commonly obtained for the last 5 years? Okay, so when you have that data, you're sitting on a data mine and you can tell for sure you have this data, you can tell with conviction something with evidence and with proof. Okay, so these are the other activities that we add on to our natural sensitization programs. Next slide, please. So we have to do area monitoring. We go out to inform patients. Now this patients, they should not think, and they have this wrong notion. They have a misconception that ADR is coming because doctor gave me the wrong medicine. Sorry, this is not the truth. With contemporary medicine or with Ayurvedic medicines, Unani, Siddha, homeopathy, nothing. Okay, it is that how your body is responding. Sometimes you may be taking many other drugs or food materials that can also have a interaction and so cause a reaction. Okay, so patient should be told this, and then we will be coming to the types of adverse effects and all. So these have to be, sensitization should be there, and that is how you work it out. Next slide, please. So we have come to the various steps of activity. We should have a pharmacovigilance person. PVA is usually appointed, and this happens only if you're giving a good number to the NCC. Then they will appoint one who is paid by the NCC, by the government. But otherwise, we keep our own. See, we don't have to look forward. This is something you and I have to do. We will do it. We are lucky to have a PVA, but even otherwise not, we would be continuing to do the good work. Next slide, please. So we have many targeted programs that go, even the immunization, there is vigilance, that is to medical device. Friends, I would ask you also, you all are doing procedures, isn't it? Sometimes the procedural thing, I have taken Shirodhara and all that, those things, they may not work, something goes wrong, that should be also reported. That will be the next development. So first we talk about pharmacovigilance, drugs related, then we talk about vigilance and all, we are evolving and trying to do the best. So this is in pharmacovigilance. We have these various programs for following immunization, adverse events. We have hemovigilance. We have in Amrita, we are lucky. Sir Bedekar, sir, you must be happy to know we have Pharmacovigilance Center, Material Vigilance, and Hemovigilance is running. And now we have this Ayush Vigilance in our Ayurvedic Medical College. So we are there to help the country in developing more and more. So next slide, please. Next slide. So we have many other, this I have already mentioned to you. Next slide, please. Yeah, so these are the steps that are going on into the formation of your AMC. Next slide. We have already formed, so you all are well aware of this. And as we see, we do more projects and research work with the acknowledgement from the national. And you should also acknowledge the NCC, the center, when you are doing it. You have to take their permission and do it, okay? And when you publish, you should inform. Now, this is the National Pharmacovigilance Program of the Ayurveda Siddha Unani System, ASU. And this is the program for which was started way back in 2008, 29th September, it was launched. And what does it do? It is informing, collecting, collating, assessing, and putting in measures in place. In addition, it has to be communicated to the authorities and to the public at large. Okay, only then it comes full circle. So this is the mandate of the National Pharmacovigilance Center, right? Next slide, please. These are the forms. That form, first one is for the contemporary conventional drugs that we use. This is the material vigilance, medical device related adverse events form. And this is the presently which we use for Ayush. It is a 2-page form. This last form, we will go into the detail. I'll teach you how to fill this form. This is the latest form that we have. Next slide, please. So, so there are, this coordinating center is in All India Institute. In Dr. Galib is from there, from AIIMS Delhi, Ayurveda Center in Delhi. Next slide. Yeah. So we have certain terms that we have to know. These are the intermediary centers that are there for pharmacovigilance. From the, so the intermediate centers, Jamnagar, sir is from Jamnagar, right? And Jaipur is there, Bangalore, all these places, and Calcutta further. So these are the intermediary centers, and you can always meet up with them to talk to them about it. Now, there are some terms you need to know. Who is a notifier? Who has experienced or watched the adverse regulation? Who is the reporter? Any healthcare professional is the reporter of adverse reactions. Next slide. So we have also what is, these are, what is a side effect? Side effect is an extension of the needed pharmacological effect at therapeutic doses. When it becomes higher than therapeutic doses, it is not a side effect, okay? And these are, this is because of, there is adverse event or adverse exposure. Adverse event from adverse drug reaction, slight difference that it is having a causal relationship to a pharmaceutical product, not necessary. It's unintended and noxious, harmful. Next slide, please. Now you see here, what is a signal? When you give all the reports, something that looks like a commonly mentioned thing, that is converted as a signal. A red signal, no? You see, like a red herring, it is called as a signal, okay? That is the actual definition of it. Don't break your lovely heads on that. But you should know from, if you report, we get a signal, and then we can be more watchful. Next is the unexpected adverse reaction. We know known adverse reactions are there, and there is unexpected adverse reactions, and there is also SUSARs, suspected unexpected adverse drug reactions. So when you get all these unexpected reactions in many, that time it will come to a, it will be added into the drug brochure IB that you can write as a, now you can write it as a adverse reaction. Okay, then it becomes an expected adverse drug reaction. Next slide, please. Yeah. So this is what you mean by adverse drug reaction. This is the definition that is told. This you have already been told. So adverse drug reaction, noxious, unintended, and occurring at therapeutic doses. There's a causal relationship. It only happened after the drug was given. You know that causal or temporal relationship is very important to note. Next slide, please. Yes. This is a repeat of the unexpected adverse drug reaction. Next slide. That was a repeat. Okay. What is a serious adverse reaction? Sometimes a patient takes a medication, a little later his hospitalization, if he's there in the hospital, will be prolonged. Or who was not hospitalized is being hospitalized. Or there is a congenital anomaly occurring. Okay. And there is a disability that happens. Then all it is considered as a serious adverse drug reaction, and this has a legal connotation. So it has to be informed. I'm not talking only for the sake of drugs that are being studied on a clinical trial kind of basis, but also when we are using in therapy, we have to report it quickly because it is a serious adverse reaction. Next slide, please. So this is adverse drug reactions again. Side effect adverse, there are many: side effect, untoward effect, and toxic effect. So side effect is one which is predictable. We can predict its kind of effect on which organ, and it is occurring at therapeutic dose, and it does not require mandated withdrawal. Untoward effects may be predictable or not, and it is occurring at therapeutic dose, and it need not be withdrawn. Can withdraw with toxic effect, you have to always withdraw the drug, and it is unpredictable but occurring at higher than normally used doses. Okay, next slide, please. The commonality, how common is adverse drug reactions? This picture you should have in your mind to know. When we say very common, 1 in 10, common when you mean between 1 to 10, more than 1 to 10. So these are the ways that we tell. How much is rare? 1 in 10,000, very rare. Okay, so this is a criterion that has been put up by the IPC that is given to us about how you say the how common it is or how rare it is. So this is one criteria that you have to know. Next slide, please. Yeah. Now I have a case. Okay. This is a case that has been, which has occurred. So would someone like to read it? Sir? Yeah, you can sit down.
A 31-year-old male visited complaining oral ulcers for the past 5 days. Nutritional related factors, vitamin deficiency, possibility for local injury have been excluded. No major systemic pathologies could be seen in the patient. He was prescribed with Chitragadi Vadi, 500 mg thrice a day for the past 7 days. That was advised to chew for the management of RA by an Ayurveda physician. The symptoms are being managed.
This is what we have to, this is the first page part that is coming. Next slide, please. Are we clear how it is coming through? Okay. So there were no more. That is the list that was put for all other drugs that could be given. You see how we have written the other points too. Next slide, please. This is ultimately here, usually in pharmaceutical products, we usually use the WHO criteria for causality assessment. But for here, Ayush drugs, we are using mainly the Naranjo's criteria for causality. Okay, that is the one major difference that occurs, and this is how you put the probability. This is how the probability is assessed. Next slide, please. Now, this is coming to the end of my session. So that was one case you saw, and you saw how it has to be reported. We have to get many more such reports. This is another case scenario that has been given. Would someone like to read, madam?
A female of 51 years old presented of the OPD with burning sensation in the chest. Examination revealed no other systemic pathologies. She was consuming Yogaraja Gugulu 1000 mg twice a day after food since 10 days for her knee joint pain with lukewarm water prescribed by an Ayurvedic physician. On further investigation, she revealed having similar symptoms 2 months back on consumption of Yogaraja Gugulu that were disappeared with the withdrawal of medicine.
So, what is this? How would you consider this? That one you cannot be sure. Okay. Whenever you have a problem, and the problem it became fine. The patient's chest pain and all that became better. But you saw when the tablet was again given, this Yogaraja Guglu was again given, what happened? She got back the symptoms. Okay. So that means there is a word called re-challenge. You remove the medicine, patient becomes all right. That is called de-challenge. You remove the offending drug, that is called de-challenge. Re-challenge means when I am re-giving the drug, you will experience the same. So this is a type of a reaction which is a certain. Correct, no? Every time we cannot give certain. It's not always certain. This luckily is a certain kind of a reaction where you are getting it back. So it proves that this happens because of the drug that was given. So you should look into the past history. You should ask, have you taken this medicine before? That time did this happen? So that you can understand. Okay. So this is how a diligent doctor will find out how a drug and an adverse reaction is. So just getting an adverse reaction is not it. That is not the end of it. The end of it is you're finding out how common it is, and then finding out how to correct it and how to prevent it in any more patients who will be taking this medicine. That's our ultimate aim. Our aim is to treat our patients, and they should be safe. They should be safe from any harm or risk, and they should get effective therapy. That's all we want. You want, I want, everybody wants. Even if I'm a patient or you're a patient, you would also want that, right? So ultimate aim, friends, vigilance is necessary, and you and I have to do it. Do you agree to report? Then only the numbers will increase. Okay. Thank you all. Patiently. Yeah, please.
Long-term side effects means if you're using a medicine for a long term, how can we report those things?
Yeah.
Same.
When you suspect, in the whole thing is, do you suspect that it is an adverse reaction? That is the question. If you suspect it is a probable, this is not happening with the disease. This is not happening because of the usual way of the drugs that are there and all. So this is something different. So that suspicion is coming in your mind, you report. Whether it was long ago, today, tomorrow, when you find it, that time you report. As early you report is best, but even if you report later, you had such a case like this that time also, then you can also report even that time. And sometimes after filing a report, then that patient died or something happened to the patient further, you can add on to that patient's case. You have to just remember that number, we have it, and to that you have to add on. This is how we build the data. Medical knowledge data is built, and that is how we can stand on it. Okay. Yeah. Any more questions, Surely?
This Yogaraja Gugulu.
Yes, it has been reported, sir.
But that person to person that may vary, no? That means someone have the symptoms.
You are telling of this patient.
Okay.
Okay. patient with Yogaraja Gugulu will not have it. If there are some, you got in Kochi, in Kollam, another person is getting 10 or 20 in Tamil Nadu, or maybe in Tamil Nadu and Kerala it is less. But say in Northeast or in Delhi or Himachal, it is more. Okay, it is very much more. So what is the meaning of that? There may be some food characteristics or something that they are doing. Yeah, yeah. So that is the reason why, sir, madam, we all have to report. Only when that whole thing comes through, you can see the trend. Sir, you may say nothing, patient is fine, and then he went. No, you still report. Okay. So like that, people along the whole country is reporting, then you will see that when the National Coordinating Center is sitting in the meeting, they see that and you can understand that it could be a possible or it is not a possible thing, you know. And supposing this is nothing, yours would be the only case, it would just fizzle out. No problem. Okay. But if all of this drug was causing so much in so many patients, shouldn't it be worry, sir? Then it will come out as a warning. It comes as a caveat. Okay, that's it. There is no harm to you. Reporting doesn't make you a bad doctor. If you are reporting means if Princy has reported and my colleagues have not reported, does not mean that Princy is the bad doctor who is getting all adverse reactions. Sorry. I am a good citizen. I'm a good doctor. I'm a responsible doctor. Okay. So don't take it as a negative. And mind you, all this, what you're going to report, it's not going to cut down your salary. It is not going to de-incentivize you or not give you promotion or no such thing. This is an academic exercise. It is your duty as a accountable physician. Okay. Today it is accountable. From your heart you're doing it. Tomorrow it may be mandated that you do it, and if you did not report a ADR, then you will be penalized. It will come in later days. Okay. Right now it is just from your voluntariness, out of your responsibility, out of your wish to be a accountable doctor. Okay. That you're doing this. Okay. So aren't we great physicians? We are accountable, we are law-abiding citizens, and we will do vigilance because we want best for our patients. Right? Any more questions? Thank you.
I invite Dr. Ramesh NV to present the token of love.